So, Dr. Pradhan, sir, will just be joining us in 5 minutes. So, once he joins, sir, we can start.
Okay, no problem. Whatever is good for you
Yes.
is okay with
Yes,
us.
sir. Just 5 minutes. So till then, I will just like to introduce Dr. Rakesh Katna. He is a alumni of Tata Memorial Hospital, Mumbai, and currently a consultant in Mumbai at various hospitals. So to name a few, Jaslok Hospital, Bombay Hospital. Then he has his own center in Thane, which is called as Titan Medicity, where he does even he has started robotic surgery. So on minimally invasive thyroid surgery before we go on to the panel.
Yeah. Thank you, Karthik. Yeah.
Yes, sir. So till then, sir, you can just share your presentation, and once Pradhan sir joins us, you can then start.
Yeah, absolutely. We'll do that. Yeah. So you'll send me the link, this thing to share.
I think you there will be an option, sir. You
Yeah,
will.
yeah, yeah, I'm getting that. Okay, I got it. Just let me know if you can see the presentation.
Yes, yes, we can see,
You,
sir.
you can see, right?
Yes.
Okay. Yeah, sure.
The most important aspect of the meeting is to get your presentation on.
Yeah, right, sir. Absolutely correct. And I got a surprise for you. So it's like we have listened to so many conferences, so many talks of yours. So the first slide is actually dedicated from one of your slides only. So we'll start with that once everybody's on the
Okay,
board.
great.
Yeah.
I look forward to that.
Yeah, sir.
So where did you learn the minimally invasive? In Korea?
Yeah, sir. I was in two places. So initially at Vietnam, Hanoi, where I
I
did
see.
my fellowship for trans auxiliary, and then robotic in Korea. So these two places I worked
I
from.
see. Okay.
Yeah.
So you've not been to Thailand for transoral.
No. So I just started transoral this year now. So initially I
I
was
see.
doing only unilateral trans auxiliary, now Baba approach, and now
Okay.
shifting on to transoral as well. Yeah.
Okay.
So we have around 102 participants joined, which is quite a good number.
That's a very good number.
Yeah.
What are these people doing? They're not having dinner Saturday evening?
So dinners here are quite late. So probably
Oh,
by
I see.
after
Okay.
finishing the this webinar, they'll directly head towards the dinners only. Dinners
Yeah.
and drinks. Yeah.
It's quite early morning here in New York. It's 6:30 in the morning.
Okay.
The the best thing is it is a truly full moon day today here. It's a
Oh.
special full moon day.
Oh,
And I
that's
can see
lovely.
the whole moon through my window, which is wonderful.
Oh, lovely, lovely, sir. But for sure, your air quality index must be much better than ours.
It's quite cold here. The average temperature is around freezing point, 0, -10. And if
Yeah.
it is wind
Okay.
chill, becomes like -20 degree.
Right.
Very bitter cold.
Right, sir.
So Karthik, who is going to present the case?
Sir, so the panel it's a panel, sir, which I will be moderating, sir, and
Okay,
there are total of six panelists. So,
okay,
yes, sir, it's like a panel discussion.
no problem.
So the other three, Pradhan sir, and Dr. Rakesh Katna are three panelists, and the other three panelists will be Dr. Deepa Nair from Tata, Dr. Sandeep Nayak, who is a robotic surgeon from Bangalore, and Dr. Siddharth Shah, who does mainly transoral thyroidectomy. So he's from Ahmedabad.
Great, wonderful.
So I tried to take all the panelists who are actively doing robotic surgery so
Sure,
that we can have a
absolutely.
meaningful discussion.
Yeah, that's wonderful.
So we just did our first transoral thyroidectomy last week, sir, in our hospital. So
Oh, very nice.
Dr. Siddharth Shah from Ahmedabad came over and he
Yes,
demonstrated the surgery.
very nice.
Mhm.
Wish you all the luck, Karthik. And 2026, then we hope that you'll be doing more and more minimally invasive
Yes.
approaches for the thyroid.
Yeah. Thank you, sir.
Rakesh, the question is it minimally invasive or maximally invasive?
Yeah, yeah, correct, sir. So you just went for the juggler at the start only. So you can say it remote, but maximally invasive in most of the cases, actually. Yes.
Right.
That we will discuss during the panel.
Yeah,
Yeah,
yeah, yeah.
absolutely.
But I would say that only that classical open conventional is the minimal invasive approach at the end.
Uh,
Hi, good evening, sir.
Evening. My apologies for being late.
Good evening, Sultan.
Hi, where are you? Ashok, I can't see you. Oh,
Yeah,
yes.
I'm here.
Hi, how are you?
Pretty good, thank you. Thanks for being here and inviting me. Wonderful. Go ahead.
So I think Dr. Katna, you can start.
I'll start.
Yes,
Okay.
yes.
Yeah. So, yeah, you can see the slides well, right? Yeah.
Yes,
Yes.
yes.
Yeah. So, good evening, all of you, and thank you, Karthik and Pradhan sir, for giving me this opportunity to be here in presence of Dr. Shah is there, all the doyens, you, Dr. Shah is there, along with the other speakers who are going to join us for the panel also. So I'll be speaking today on minimally invasive approaches to the thyroid. We'll live briefly about its indications, when it's been used, its role in even in thyroid malignancies also a bit, and some videos pertaining to different approaches. So I'll start with, as I told Professor Shah also. So in his lot of lectures, the euphemism which comes that he has so many times said that only approach which is left now is the transrectal thyroidectomy, which is the only approach left so far. With all apologies and your permission, sir. So I took and went to the chat GPT and just give a prompt to him that what will be the it look like if we go for transrectal. So this is what chat GPT turned out to be. He gave me the picture.
Mm,
So, looking at the history, now the first, if you remember, 1996, the first cervical surgery was done for a parathyroidism, parathyroid adenoma excision was done at that time, and lobectomy of the thyroid in the subsequent year by Dr. Husser in 1997. So it's almost 27, 28 years since the first advent of endoscopic approaches to the thyroid, and then we have seen, uh, 1 second, yeah. We have seen so many approaches which has come down right from video assisted central approaches like Mikoli's technique, minimally invasive video assisted. Then the breast approaches were started, bilateral axillary breast or unilaterally axillo breast approach, the Baba technique, which we call normally transaxillary unilateral approaches, retroauricular, lateral endoscopic, anterior, and Toitava, the transvestibular, which is one of the most commonly used now. So we have seen that we have come a gamut of approaches in last 25 odd years to find out what will be the best minimally. I'll not say the minimally, we'll again see at the end, but remote access to the thyroid to avoid a scar. So generally we divide minimally invasive thyroid surgeries. I prefer to divide it in like three ways. One, open surgery with a small scar. We call it minimally invasive open surgery, like Terrace et colleagues in US. They demonstrated in 2009 onwards minimally invasive with 3 centimeter, 2.5 centimeter scar. Or Mikoli, which he did like video assisted gaslight techniques. A lot of techniques came. Mivat, video assisted neck surgeries, which were very popular in Japan initially. They used Kirshner's wires to raise the flap and to go inside and dissection. So all these, apart from retroauricular, did not hold the test of time. Slowly and slowly, only I think Mikoli's Mivat technique is being used in a particular setup there in Italy. Otherwise, everything is shifted to pure endoscopic approaches when we talk about the remote access, which is transoral, trans breast axillary combined, or when you add robotic to that, either transoral robotic taught or otherwise Baba approaches for the students bilaterally axillary breast approach. So these are the approaches to the thyroid. That doesn't mean that we do minimal dissection, but these are the pathways of the dissection to reach out the thyroid gland. So this is bilaterally axillary breast what we see. And then if you want to go for unilaterally axillary breast, this is areola, axillary link again, pedio. This is gasless technique. Then insufflation with CO2. Then you can put 2-3 ports and go for axilla, retroauricular, and toitava or the transvestibular one. So what I'll be briefly initiate discussing first is the lateral access of the transaxillary, which I'm doing from last 7 to 8 years now. So that uses a very simple approach what we use in our conventional surgeries also, that is a lateral access or the back door or the trap door what we call it, that we are using the plane between the sternocleidomastoid and the strap muscles to reach down from one axilla over the pectoral area and to reach the thyroid gland. So advantage of this lateral dissection is that thyroid is exposed very well, as we know in open surgeries only. If you just medialize your strap muscles, you will be directly onto the thyroid gland. Your superior pole is controlled very easily. You are directly on your structures where your money is on. That is your recurrent laryngeal nerve and your parathyroids, which are very well seen. Now, magnification, yes, it helps. It helps immensely to identify the parathyroid and recurrent laryngeal nerve, though it does not substitute the anatomical knowledge where to find them, but it definitely helps in easily identification if you see them. The landmarks which you have to use is same as in a conventional thyroid surgery. Again, a left-sided recurrent laryngeal nerve, as we always say that it's little easier to identify in the groove as compared to the right side because of its straight course. But generally we use all the same principles what we use in conventional open thyroid surgery. So main dissection principle again, that dissect and control the vessel as close to possible to the gland as possible to preserve the blood supply of the paras. Simultaneously avoid the perforation or the rupture of the nodule. In endoscopic approaches, what we use is instruments from a long arm. So there are longer instruments. Handling them require a little bit of practice, but avoid perforation or rupture because that will lead to bleeding. And you know that you're working in a magnified field, whether you're working robotic or whether you're doing in an endoscopic assisted. So any bleeding on that screen would look multiple, it look like bigger. So you don't want to obscure your vision or access. So avoid perforation or rupture of the nodule. So handling is very important. And we have to understand the basic concept that understanding the anatomy, having the experience of adequate open thyroid surgeries before, and a very basic knowledge of laparoscopic surgeries must to go with endoscopic assisted, and laparoscopy is not required if you're directly going for robotic procedures. So what nodules generally we take it out? That is, if we talk about the benign nodule generally, Bethesda 2, 3, and 4, less than 5 centimeter size for the benign and less than 2.5 centimeter for malignant nodules. The gland volume should not be very big to handle, to rotate it because this space is little constrained space and you are working with only two instruments over here. There is no third hand until unless you're using a robotic extra arm. And they should not know thyroiditis because again dissecting off the plane, as we've seen even in open surgeries, it becomes difficult to dissect. So here it will lead to more bleeding, ooze, and difficulty in the dissection in the lateral gutter especially. There should not be any previous neck surgery or any history of radiation so that your planes are very difficult to raise and to reach down to the gland becomes more difficult. Exclusion, as we say, more low risk papillary carcinoma, small size P T1, T2 can be considered. Apart from that, any other pathology like medullary or any other malignancy, tall cell or any aggressive variant, you should avoid that. Any enlarged major lymph nodes where you only have to do a minimal access thyroid procedure along with little central compartment dissection, then you can do this. But if you have multiple large nodes, it's better to consider for an open surgery. Gross extrathyroidal invasion, which you see preoperatively, then also these patients are not suitable for minimal access approaches. Again, obese patient and substernal extension depends upon your experience once you keep on doing the procedure. But initially in your career, you should avoid these patients. So these are the relative contraindications for minimal access. So this is how our routine OR setup look like. Patient is in a routine position, what we give in open surgery position only. What we use is 3 ports. So this is cranial end, this is the caudal end, this is the endoscopic arm or the camera arm in the axilla, one in the areola and one in the acromion. So this is the plane, a triangle we are dissecting, reaching out to the gland, and this is how after the surgery the patient look like. So one stitch each and drain is placed in the axillary fold. So we'll just get down to a video where we'll explain this procedure in detail. So what we use in all gas approaches or gas insufflation approaches is that we use three ports, and we use carbon dioxide insufflation like what we use in our routine laparoscopic procedures. Carbon dioxide pressures, initially we used to keep it little high at 9 and 10, but now I keep at 6 to 7 millimeters of mercury and the flow rate at the same 6 to 7. So as we discussed, camera port in axillary fold initially 0 degree, after that 30 degree, which is the most common endoscope used. It's a 10 millimeter 30 degree endoscope, same what is being used for general surgery people for their laparoscopic surgeries. And two instruments port, that is 5 millimeter acromion and areola. So this is a small video where we can see that how dissection is done. So this is the camera port in the axilla, and then two instrument ports are introduced. Right side, this is a right-sided nodule. Right hand, this comes from areola, and left one comes from acromion. So dissection is done over the chest to reach down the clavicle. This is clavicle, and then we identify the sternocleidomastoid fibers. So here I'll just pause a little bit. So after reaching in the neck, you continue over the clavicle under the subplatysmal planes. Basic first thing to identify is the sternocleidomastoid muscle. So this is the medial border of the sternocleidomastoid, and the strap muscles we can see over here. And now I'm using the right hand side is a harmonic device, and left hand side is a suction. So these are the strap muscles. You can see the bulge of the nodule here, ansa cervicalis on the lateral border of the strap. You can see. Now, depending upon the size of the nodule, generally we avoid cutting strap completely, but we define the straps. This is the omohyoid muscle. So first muscle after that you see is omohyoid. You define the superior belly of the omohyoid. With pressures of carbon dioxide, it automatically opens up the space and omohyoid shift down superiorly. So there is no retractors which we are using, but we are using carbon dioxide only to create a space like what we use, the other surgeons use in abdominal procedures. Now you can see, yeah, I'm just delineating the omohyoid. So take it out of my way. So it goes superiorly. Now, depending upon the size of the nodule, generally it's easy to take out the whole strap muscle medially, but sometimes we have to linearly split the strap fibers over here so that to expose the gland well. So this is the thyroid nodule being exposed. Some amount of thyroid muscle being split so that again space is created. This was a 4.5 centimeter bulky nodule. Now, similarly, superiorly also. So I'm not cutting the strap muscle horizontally over here, just a few strands. So what we are seeing is a very magnified view. So when we are seeing it, we are just cutting linearly a little bit of strap. There is a lot of background noise by somebody. Yeah. Yeah. Thank you so much. So the idea is to identify this is the superior pole. Okay, so all strap muscles are away. We are dissecting lateral. So as we said in lateral access, this is the superior pole. The superior pole, high riding pole can be seen over here. And this is the first glimpse of a parathyroid also, which we just saw. So that's the superior thyroid vessel and the middle thyroid vein. Again, you can see it is looking very large because it's a magnified view. I'm using harmonic to seal the vessel. You can use a clip, a hemostatic clip or a titanium clip, or otherwise you can just seal directly with the harmonic also. Make sure that the jaw, which is insulated, this white color jaw that is remaining, that is closer to the glands structures which you want to save, so that not to dissipate any heat energy. So now after taking the superior pole, we, as same as what we do in our routine surgery conventional open technique, we are going to dissect open up on the inferior pole. So this is the trachea. You can feel it, you can see it with the endoscope also, and then you can take the vessels along close to the gland, as close as possible. So these are the inferior thyroid veins over here, branches. So you can take it again. Harmonic, it's a very good sealant device. You can seal and cut at the same time. And for these kind of procedures, it can make your life very easily either a thunder beat or on a harmonic focus, which you can use. Or otherwise, alternatively, you can use in a bipolar also, which is very much available in laparoscopic instruments. So, superior pole is released, inferior pole is released, and after that, the attention is diverted towards the lateral gutter. Again, we have to remember that stay as close to the gland as possible, because majority of the time when we are doing these approaches, we are doing it for benign, and there is a very good capsule, so you can just dissect along the capsule, let the important structures fall down into the gutter. Here you can see with my suction, the movement is there. We can see the inferior parathyroid. So that is the inferior parathyroid, little intracapsular over here. But you can very well see the roving sign, that is with the movement of the fat. It moves like it is floating in the fat, like in a boat. So then we put our attention to identify the next important vessel again in the gutter you will see is that is the inferior thyroid artery. So this is the inferior thyroid artery making its Y branches over here, which will supply to the parathyroids. So use your devices, either this harmonic or otherwise a Maryland bipolar in your right hand or left hand to dissect. Utilize it like what you do it in a mosquito or artery forceps, which you use in conventional surgeries. So here the glimpse of the inferior parathyroid is seen. Now the gland is being rotated completely medially by putting pressure from this soft suction. But same time, I'm making sure that I do not puncture or rupture the nodule. So that pressure should be adequate. So this is the tubercle of Zucker candle area. We can see the early glimpse of the recurrent laryngeal nerve here. I'll just pause it a bit here. So this is superior pole, inferior pole, tubercle of Zucker candle, which very well seen. It points towards both para as well as the recurrent laryngeal nerve. And this is the inferior thyroid artery, which is crossing and giving the blood supply to the parathyroids. So that's a classic picture which you want to see in every thyroid surgery while protecting all these important structures. So our plane of dissection is going to be here above this. So I'm just releasing a little bit of superior pole here, but above the para intracapsular will release it so everything falls down. We can see the recurrent nerve over here with its branches as well. Uh, yeah, you can hear now.
Yes,
Yeah.
yes.
Yeah, yeah. So we are dissecting as we discussed above the parathyroid glands. So a little intracapsular over here, let the every important structure fall down. And please just see that you have to be extra careful that your insulated part of the jaw of your harmonic should be downwards. So again, as to avoid dissipation of heat into the lateral gutter, absolutely, so that there is no thermal damage. Now, after freeing the gland from everywhere, this is the last few attachments of the ligament of Berry, which you again will cut. Take care that even the jaw over here on the trachea is also again away from the tracheal side, because this is otherwise it generates so much of heat that you can have an injury to the trachea. It can make a hole in the trachea also if you keep it for longer time with the uninsulated jaw. So last few attachments is being cut, and then it is being released from the attached strap muscles. So all the strap muscle we see medially rotated. Now this gland is completely free. You take out the gland, then you just park it over the sternocleidomastoid or the chest area for time being. Go down inside. We can use a wash at the same time and go back, see the gutter. If you want to place a gel foam or any other Surgicel or any other flow seal, you can use that, but generally there is no need because harmonic works very well. An endo bag is introduced to put the specimen into the bag and taken out from the uh, camera port, which is your axillary port, without increasing it. Sometimes if the gland size is bigger, then you can make it to 1.5. But once you put in an endo bag, it is very soft. Generally, the thyroid gland, as we know, it's very soft. So with the squeeze movement, it comes out through very well. So we have experience of almost 152 patients so far with mean age of 32 years. Operating time, mean operating time is 97 minutes. So initially when we started, it was quite a long time, and then so after some time, as with the experience grew, then the time shortened on its own. Average blood loss is only 20 to 30 ml, and hospitalization is only for 48 hours. And these patients by third day are sent home. Drain is put in all these patients, as we saw in the last day, from the axillary port only. Looking at the complication, there were no permanent complication. Transient, two patient had recurrent laryngeal nerve paresis, which recovered on its own after a period of almost 12 weeks. Hypocalcemia was not seen because all these patients were hemithyroidectomies. Seroma in patient, one patient was seen intraoperative, one patient had bleeding by rupture of vein, which was managed with the help of harmonic device at the same time. Three patients we had to convert to open because one patient had severe thyroiditis and one had an inferior extension of the nodule going into the substernum, which was difficult to dissect. And one patient developed a little skin redness. So to avoid any injury onto the skin by heat, then we decided to convert it to open. Apart from that, there was no major complications so far. So now the second approach, as I'll discuss, there are people who are going to join us. Dr. Sandeep Naik, who does with the rabbit approach. Here, what I'm explaining is courtesy Dr. Dabas is a BABA approach, or the bilaterally axillary breast approach. So here, as we saw, similar what we did in transaxillary, just consider it that upper port is gone from here acromion, and you have put in two ports from the opposite side. So it's the same carbon dioxide insufflation technique. You create a space, put, with the interest of time, I'll just shorten it a little bit. So you put two ports from the right side, areola, axillary fold, put CO2 insufflation, then create a space. So here the dissection is medial dissection. So that is, you go between like standard open midline dissection rather than a trapdoor, but you can convert into a trapdoor also depending upon your comfort. It's feasible for both. The advantage of this BABA is that you can do a total thyroidectomy by coming in from all these four ports. So idea is to reach in the midline, that you identify the sternal end of the clavicle here, identify two ends of sternocleidomastoid again. So you can see the fibers of sternocleidomastoid. This is the right side. Right hand is using a monopolar cautery scissor. Left hand is a bipolar Maryland. So we are dissecting the plane again, going subplatysmally, identifying both the sternocleidomastoids, go superiorly up to the sternal notch, thyroid notch, and then inferiorly up to the sternal notch. And then you dissect in the midline. So I'll just forward a little bit. So this is now the introduction of the third arm also. So right now we are using four ports: right axilla, right breast, left axilla. So you can see three instruments and one is the camera. So one instrument is extra instrument is being used over here to give traction. So this is the midline now. This is a strap muscle. So in the midline between the two, the sternocleidomastoid. So this is the opening of the midline strap muscles. That is again that you identify your jugular veins or see the linea alba, then cut it and open up the midline straps. This extra arm gives the leverage that it gives a constant traction, which is like that you are having an assistant during the procedure. And you see the magnification over here is little slightly better as compared to endoscopic, which is the advantage with the robotic. So this is opening up of the midline completely superiorly till the superior notch. Thyroid nodule is being seen over here. Thyroid nodule all around. We can see a very good plane is you can use this scissor without using the cautery function of the scissor, or you can keep the cautery at very minimal, but you can use like a scissor for dissection. And the left hand side, both these instruments have bipolar functions. So this is the nodule in picture. Then this is the lateral. We can see the carotid artery. Now, reeve space. dissection to identify. So it's like camera moving here becomes easy because surgeon itself only has the control of the camera as opposed to what you have in your laparoscopy. So you can move it along with your movements wherever you want to. So this is superior pole vessels here. You can just bipolarize. You can use an again a hemostatic clip also if required, depending upon the size of the gland. If you're taking the vessels too close to the gland superior pole, then you need not to take clip most of the times. You can just bipolarize the vessels. So after that, now this dissection is at the inferior pole, inferior thyroid veins being dissected off. So this is the caudal end of the nodule, and this is the trachea here in the midline. So this is the midline. So it's being separated from the midline. The lateral gutter is yet to be dissected off. So small vessels, again, you can just bipolarize and cut with the help of scissor. Again, the idea is to mobilize the gland both superior and inferiorly so that you can rotate it completely to visualize the cutter. Now, one more advantage with the robotic comes down. Yeah, here you can see the recurrent laryngeal nerve starts appearing. Uh, one more advantage is here. This is the recurrent laryngeal. This is the inferior thyroid vein, but this is recurrent laryngeal nerve in the gutter. I'll just show you here. Yeah. You inspect it for any lymph nodes. This is the inferior thyroid artery. The branches of inferior thyroid artery, branches going to the parathyroid. So that's the recurrent laryngeal nerve in the inferior thyroid artery, which is going below as opposed to what we saw in the previous video. Now the advantage, now you can see the vision changed. So how? So in robotic, you can shift the camera arms from one side to another side, which is generally not possible when we are doing a laparoscopic approach because in robotic Baba approach because the trocar size is different. But in robotic here, the trocar size is bigger, that is 8 millimeters, so you can change the hands. So this is after releasing. Now the camera is on the right side. You can see the lateral gutter completely, the recurrent laryngeal nerve area. This is the last attachment of ligament of very superior parathyroid is very well seen over here. You can use intraoperative nerve monitoring also at the same time, which can be connected to as a connector to the monopolar cautery, and you can just attach that. We'll also discuss in the subsequent slide, and you can check for the integrity of the nerve as well as that thing. So this is attachments of the ligament of Berry, and then medially here ligament of Berry is released completely. You can see again the magnification is so good that you can see the trachea and the planes very well. Nobody. Yeah. So this is the after the gland completely is out. This is the division at the isthmus at the end. So no need to suture the opposite side of the lobe, which we generally don't do in open surgeries also. The whole gland along with the isthmus is out. The right hemithyroidectomy is done. And you look back at your gutter. You see for this thing, you can see the recurrent laryngeal nerve. You can see the inferior thyroid artery in its branches supplying to the para and the tracheal along with the vessels. Then sutures needs to be taken. You can take a braided sutures or otherwise simple vical sutures, tie a knot like what we do in routine open surgeries and keep a drain from one of the axillary port. Again, use an endo bag to remove the specimen. So then transvestibular approach. So I'll again shortly briefly show a video about it. This is courtesy Dr. Siddharth Shah only, but this is one of our patients which we did. So this is the general appearance of the patient in the operating room. You have 3 scars, one in the transvestibular horizontal, and 2 for the 5 mm ports. And we'll just see it in the video over here, a brief 5 minutes video. So this is how the marking is done. One horizontal scar which is used for 10 mm port, which is used to introduce your camera port. Basically, you do blunt dissection over here with the help of an artery. So idea is to create a plane over the chin and go into subplatysmal plane in the neck area. Then you widen this plane a little bit over here. So you are above the mandible and using a Hagar's dilator to dilate that area so as to put on a 10 mm port, which is your main port, the camera port, which also have CO2 insufflator attached to it. So this is how the camera port is being placed. Then lateral incisions 5 mm from the angle of mouth on both the sides have been taken. A little hydrosaline dissection with a syringe go into the again into the subplatysmal areas of the neck. The two 5 mm ports are placed. Then CO2 insufflator, again 6 mm of mercury is the pressure, and with the flow rate of 6 to 7. You raise the flaps up to the sternal notch inferiorly and laryngeal thyroid notch superiorly. Then you identify the midline over here. Initially we use cautery hook. Then later on you can either switch to harmonic or a thunderbeat. So this is separating the midline first, identifying the midline, and then now these muscles generally keep on coming in between. So what we can do is to give a traction, we can take out a stitch, as we'll see in the subsequent few minutes. So here the strap muscles are separated to expose the thyroid nodule. So this is the right sided thyroid nodule. We are looking from cranial end, that is meant towards the head end. You are standing in, just imagine if you're doing an open conventional surgery, you are standing at the head end and doing the procedure from there. So this is the strap muscle over here. So dissecting the plane between the strap muscle and the nodule, and to give a space, you can pass on a needle from the skin, and you can take this whole strap muscle bunch together and take it out so that one of your assistant can just give a traction so that strap muscles are separated and you have a plane to dissect. Again, cutting a little bit fibers initially of thyroid muscle to expose the space to identify the here the superior thyroid pedicle is directly up front. So the first thing you will identify is the superior pedicle. You can see very well delineated superior thyroid vessels here. Here, as we discussed, either we can use energy device like harmonic, or otherwise you can have vascular clip also. Two clips on the superior inside and or in between, and then you can seal it with harmonic. Then we look for our recurrent laryngeal nerve. That is, here the identification of the nerve is at the uh, either you look for inferior thyroid artery and then below it, or otherwise at the laryngeal point. You can see the nerve over here and the inferior thyroid artery perpendicular to that. So here, to rotate the gland completely, you have to dissect in the midline first. In all the surgeries which we saw before, axillary or the Baba approach, we came from side and we dissected the midline at the end. Here you have to cut down the midline initially so that you can rotate the gland from cranial end towards caudal end. So the to create a space over here. Yeah. So after releasing it below, like sealing your inferior thyroid veins and everything, again, take an endo bag, put it inside, and then you can take it out from the same incision, that is your camera port incision, or otherwise, sometime when you're using transoral robotic thyroid surgery, then you can put another port which is from the axilla of the ipsilateral side, and then you can take out the specimen from there by creating a small tunnel. Again, at the end of the procedure, you go down, inspect, look for your parathyroid colors change, any bleeding, recurrent laryngeal nerve function, and then you can close the midline over here. So it's a midline approach, the Toitwa approach, and then you can take a braided suture, just tie down 2-3 times, and it'll secure. It'll fasten in the midline. So dissection approach, as with this, we can do cranial to caudal, caudal to cranial, depending upon which approach you require, as which approach you choose. Recurrent laryngeal nerve identification at in all these important points. These what we look at in open surgery also: inferior thyroid artery, ligament of Berry, tubercle of Zicker-Candle, groove, and the laryngeal entry point, which is possible in all of the procedure, whether you're doing a transoral or otherwise in a transaxillary approach. Endoscopic thyroidectomy with intraoperative laryngeal nerve monitoring. Yes, there's a lot of data to support that, and it's being used very frequently. And we go through the same V1, R1, R2, and V2. Only difference is that we don't identify vagus normally if you're not going for any central compartment dissection. So it offers less modes for RLN identification dissection as compared to open, and we don't identify the external branch of superior laryngeal nerve. It's very difficult to identify in both Toitwa as well as transaxillary also. So that's why close to the superior pole, you identify the vessels and then go as close to the superior pole as possible. But again, delineating the superior pole vessels completely. Then intermittent IONM is generally performed over here because you are not exposing the vagus. So continuous intraoperative nerve monitoring is very difficult. Different methods to do that: either you can use a ball tip probe, you can use a percutaneous puncture and pass it from there, or the simplest is that you attach a connector to your cautery monohook or the cautery monopolar scissor of your robotic system, and then you can just touch the nerve and do intermittent IONM. So these are the patients who look like after these surgeries with hardly with no scar on the neck region. So this is very good for cosmetic benefits, for especially for the young females. Yes, learning curve is there. So what you should do, form a team. Always work with a team. Keep your assistant also handy so that you, your other laparoscopic surgeon or your other head and neck colleague or ENT colleague that can work with you. So that ensures that minimal complications and more successful results. Stick to one technique first. So either if you are doing retroauricular, either doing transaxillary, BABA or a Toitwa approach, stick to one technique first, master it. There is a learning curve, and after that go on to the different method or the different approach. Always call for a mentor or proctor in initial, because it's initially sometimes it takes a lot of time initially, and sometimes you wish that I'll stop it over here and convert to open. But if you have a mentor or a protector along with you, they can guide you through the surgery. Time is relative. So all open thyroid surgeons, when we compare our timing with open surgeries, what you take for 45 minutes to 1 hour for a hemithyroidectomy of 45 minutes, here it will be almost like twice or thrice the time, or maybe 5 times initially when you're just starting your career. But believe, with practice, the time is going to shorten. It is relative. It is not that important. You have to have the patience. Just make sure that you are not damaging or you are not giving any problems to the patient. And sometimes situations are like that you need to stay calm. Like if a bleeding happens, your CO2 pressure sometimes because of CO2 absorption increases, that you should know at that time what should be done at that point of moment. So it's like small video example here. Sometimes if you have a bleeding, you can just pass on a gauze from your camera port only, keep it pressed. So this is like normal surgery. Keep it pressed, wait for 5 minutes, let the bleeding and everything stop down, then again go down, inspect the field, and you can use your harmonic or bipolar devices to seal and then proceed with the surgery. If you feel like CO2 pressures are rising, stop the surgery, let the CO2 wash out. So all these things you should know, but stay calm. There is very rare occasions where you have to stop the surgery immediately and to convert it to open. Majority, 99% of the times you won't require that, but you should be prepared for that. So looking at these approaches, and then thyroid cancers also. So there's been a lot of literature, and this is a network meta-analysis in 2023 where they've seen that they've proven that it is not inferior as compared to conventional thyroidectomy, but they have flagged one thing, that is longer operative time. So this network meta-analysis was 55 studies with more than 13,000 patients. Large tumor size and extrathyroidal extension was as which we can say the bias that was in more favored for open thyroidectomy, which we recommend also. Longer time was seen in robotic procedure, mainly related to the docking procedure, which takes a lot of time. But when they compare the surgical completion parameters, the post-op thyroglobulin and RA ablation doses did not show any difference. Similarly, in 2023, one more paper in Frontiers, DVS 569, 98 studies taken for the inclusion criteria. They did a systemic review and meta-analysis and again identified that it does not lead to any more complications or longer hospital stay as compared to the conventional thyroid procedures. So they have in fact divided into BABA, endoscopic assisted, BABA with robotic, MIVAT, TOITWA, all type of approaches with standard of care. So fair large number of 13,000-14,000 patients, and they found except operating time, there was no significant value with respect to transient or permanent injuries or transient or permanent hypocalcemia. And there was then one more very good paper in 2025 in thyroid, that European Thyroid Association Journal, that they compared the short-term outcomes following endoscopic or robotic for patients with thyroid cancers. They did a propensity score matching analysis, but it was done retrospectively, single center data. But they took 900 odd patients where they compare endoscopic approaches versus open thyroidectomy and then robotic versus open thyroidectomy, 1400 patients. And they found that robotic thyroidectomy actually had a low rate of transient and permanent hypoparathyroidism and low rate of transient recurrent palsy. So the numbers are not very significant. The p-value was significant, but when we see it's only 1400 patients odd. But yes, they contributed it to better magnification what robotic and endoscopic assisted techniques give to preserve function of the parathyroids. So then they also classified that Clavin-Dindo grade 1 complications were less in robotic as compared to open. But again, this is a retrospective data, and we know that Clavin-Dindo grading is not very site specific. So we'll not read much into this data. So just to conclude, that American Thyroid Association also had said on remote access in 2016 also, and the current one also, that it is has a definitely a role in small group of patients who are fitting into a strict selection criteria, and you have to have an additional level of expertise and should be done by high volume surgeons who are doing high volume of thyroid or robotic surgeries, but basic thyroid surgeries should be a high volume center. So to conclude, it's a very feasible and a safe option to give. Learning curve, yes, definitely is there, but cosmetically it is superior than standard or the retroauricular approaches when you talk about the remote access. And definitely there is a role in early cancers of thyroid, as we saw in last three meta-analysis, T1, T2, generally low risk PAPCA, where you're only doing a hemi or total thyroidectomy or with minimal central compartment dissection, it can be done. Cost is similarly in conventional open surgeries in case of laparoscopic techniques, but it increases significantly when you go for a robotic procedure. Intermittent intraoperative nerve monitoring is very much feasible. And as we discussed, the cost is little high if you are going for a TOT, transfold robotic, BABA robotic, or a rabbit approach for that matter. So with that, I finish my lecture and thank you all of you for being patient listeners. Ready for the questions, or otherwise we can take it in the panel itself also. Thank you so much. Yeah, over to you, Karthik.
Thank you, Dr. Rakesh. It was a very wonderful lecture, and the videos were also very excellent, very well edited, and we could see the complete anatomy. And I am sure everyone got a good gist of how the different techniques are being done. Dr. Pradhan, sir, any comments, sir, on the presentation? Sorry.
Sir, you're
You
not
need to
audible.
unmute yourself, sir.
No, I think the talk was excellent, Rakesh.
Thank you
Excellent talk.
so. Thank you, sir.
Very good talk. And I think that we should leave the questions to the panel discussions.
Right.
How many do you do?
So initially, as I said, our data 152 patients so far. So it's divided over a period of almost 8 years now, 2017 onwards. So, but the change which I've seen in last few years, initially it was like very few patients used to come down and ask for a scarless approach for the thyroid. But in after COVID, probably after 2021 or so, in last 4 years, it has tripled what I was doing per year cases.
Everybody asks for a scar list.
Yeah,
Everybody is concerned
yeah,
about scar.
y-
Everybody is concerned about scar.
yeah, but
Even
maybe
men.
yeah, yeah. But even if compared to Korean population or Southeast Asia, our patients are not still that very pro for a scarless approach. If you see 10 patients, 7 or 8 will still say, I'm okay with the small scar. That's absolutely okay. And we are also fine. But yeah, there are few takers for this specific minimal access approaches. And it should not be offered like every Bethesda 2 or 3 nodules simple which can be observed. You go down and operate. So only grade 3, grade 4, where you require a hemithyroidectomy with suspicious features or a hemithyroidectomy for low risk malignancies. This is a very good approach. But I would
Yes,
like to hear from Dr. Professor Shah's or yours opinion also about it.
Well,
yesterday evening, I saw a girl
Yeah.
with a collar like this.
Mm.
And it was,
Rakesh, you did a fantastic job. It was very honest, straightforward. You raised both the sides of the coin. So I think the viewers got a good sense. Clearly, I mean, your expertise cannot be challenged. I mean, this is what is important, learning curve. And
Yes.
the learning curve does not come on your own. You need
Yeah.
to go to a center of excellence or work with somebody. Like
Yes.
you mentioned, the transoral with Dr. Shah. I think it is very appropriate to have a mentor who is expert and help you if there
Yeah.
is a problem. I think that is one very important. The other point I want to bring up, which has been bothering me all along, you make an incision on the areola.
Yeah.
And there are two issues here. What happens to the sensitivity of the breast? Breast is an extremely sensitive organ, and you make a cut on the areola. What happens to the sensitivity in future? That is number one. And number two, which is more important, what happens to the mammographic findings in future? We don't have any data on that. I tried to
Right.
look for it. And are there any mammographic changes which may preclude the diagnosis of early breast cancer? I don't know that, but I'm just throwing
Yeah.
that as a point of discussion.
That's very excellent point you raised, sir. So regarding the change of sensation on the breast area, so what we have seen is that initially for 6 to 12 weeks they have a different sensation, a loss of sensation sometimes. A different patient have different parameters, but over a period of time we have not done the formal assessment for the same. But otherwise the sensation comes down to normal. But with respect to your findings on mammography, yeah, definitely that is one thing which I don't think I have thought of or looked for that specifically. And one more difference, what we do is I don't take areolar incision all the times. The problem is with the breast size also. So when
Yeah,
we look at our patients as compared to Southeast Asia patients, we have patients with larger, bulkier breast. So to go through that breast will give you a lot of, it requires a lot of effort to put through the trocar.
right.
It leads to more bleeding also. So we take a
Sure.
little higher up. So I take like a 2-3 centimeter high up just below the infraclavicular region. So that's
Yeah,
a little modification we do. I think Sandeep is there. He's from Bangalore. So we'll discuss in the panel. They also do the same way. Yeah.
yeah. I think, at least in the United States, the patient who demand or
Yeah.
want remote access, they get it.
They get
And
it.
there's not every center, like in New
Yeah.
York, there are 3, 4 centers only. Not every center does it. You need to develop expertise,
All right.
and you need to be confident that the remote access surgery or transoral, whatever you choose, has the same results as the open surgery.
Yeah. Perfectly
I
said.
think that is important. And
Yes.
it is offered to the patients who want it. And generally, these are young girls who have ambition to become a model or an actress or something like that. I think that is very, very appropriate. I'm not against that approach. We just don't have much experience in every center in the United States.
Right.
I was telling you, Rakesh,
Yes, sir.
that yesterday evening I saw a young girl
Yeah.
who came with her dress which had a collar like this.
Okay.
Okay, I didn't remember her, but I'd operated upon her, and I just put this down, and she had a scar here. She was hiding that tiny little scar, but she was hiding it. And it reminded me of an article that I had read in the Reader's Digest at least 30 years ago.
Okay.
The Girl with the Ermine Collar. This is the title of that short story. You know, Reader's Digest has
Yeah.
the short stories. Someday you
Correct.
should try and Google and look it up. The Girl with the Ermine Collar, 30 years ago. At least 30 years ago, maybe even more.
Yeah.
And this girl had worn exactly like that ermine collar. So they are all concerned about this car, very
Yeah.
much concerned about this car.
Yeah. Aptly said. And it's almost 30 years now. After that, we had zeroed upon two or three approaches finally. That's one is Toitoa, one is axillary breast approaches. Yeah.
Yeah. One of the problem we have in United States about use of remote access surgery, if you are not experienced and you are in your learning curve, you spend an enormous amount of time.
Yeah.
And you can do probably 2 cases a day. When if you're doing open, you can do 4 cases.
Yeah. That's
And
true,
the
sir.
cost effectiveness always comes in the discussion. I'm not being critical of it, but that's a practicality. You know,
Right.
I would rather do 4 cases in a day rather than doing two. The other point I want to bring up is I think you need to, again, I'm going to reiterate, you need to go to a center where you have got a good mentor with whom you have worked and you have understood the intricacies. The way you presented your lecture, you know exactly what to do, when to do. And I think that comes by experience. It comes by learning from your own mistakes or whatever you want to call, or complications, and
That's
being
true.
open to discuss with other people.
Yeah.
Okay, so now shall we go on to the panel?
Yes, yes, Karthik.
Yes. Uh, is my slides visible?
Yeah.
Yes.
Yeah. Yeah.
Okay, so good evening all. I am myself Dr. Karthik Krishnan, consultant at Head and Neck Cancer Institute. And today it's a privilege and I thank Dr. Pradhan for giving me this opportunity to moderate this panel discussion on minimally invasive thyroid surgery. So we are moving on from a traditional and safe and effective approach to a invisible and functional approach. So we are joined today by a distinguished panel of experts. So I will just like to introduce the panelists. So Dr. Sultan Padan sir, who needs no introduction. So he is the legend and mentor for everyone, and we can consider him as the gold standard of or the thyroid surgery. Then Dr. Ashok Shah, he's the global expert from New York, and he is like who warns us against the over treatment, and he also shows us that reminds us that biology is over any other technology. Then we have Dr. Sandeep Nayak with us, who is the pioneer of the rabbit approach. So he is also with us. Then Dr. Deepa Nair, madam is there with us. She is the professor and head of unit from Tata Memorial Hospital, and we can call her as the academic anchor because she brings us a lot of evidence-based. She will let us know. And we have Dr. Siddharth Shah and Dr. Rakesh Katna. So they can be considered as the new guard who have learned and they have also mastered the steep learning curves of these endoscopic and robotic approaches. So welcome you all and
Thank
thank you
you.
for the accepting the invitation. to be a panelist.
Thank you, Pradhan sir. Thank you, sir.
So for over, we'll just now go through the evolution of thyroid surgery. So the initial, it all started by Cocker. So Cocker's incision was the traditional gold standard for open thyroidectomy. So we have been using it for since many centuries now. So as patients change and we have now younger and younger patients, everyone wants the cosmetic approach and they are afraid of the scar. Hence, the techniques have become evolved. So, in the 1800s, it was the Cocker's incision, which then turned to something called as a minimally invasive video-assisted thyroidectomy in the 90s. Then came the remote access approaches in the 2000s, which was done using robotic and endoscopic. Then, but these were not truly scarless because there were scars, but they were hidden. Then something using a natural orifice. So the transoral approach was developed in 2015. And finally, now we have something called as radio frequency and thermal ablation, where we are avoiding surgery totally, and it is a needle-based approach. So let us now discuss that is really scarless revolution a triumph of technology or a triumph of marketing. So we will discuss in this panel. Are we compromising safety for cosmesis? So let's find out. So initially, I would just like Dr. Pradhan to give his experience till now. How has thyroid surgery evolved all these years, sir, in your 50 years of practice?
I think that in the open surgery, what has really evolved is
मैंने उसको पूछा पोस्टर ऑर्डर डाले
I think Karthik, you will have to mute the others.
Yeah.
मुझे लगा कि आप ही देख लो तो आप ही डाल दो
ये किसका है? उनका यही है ना?
होटल और
Uh,
चार्जिंग शीट भी मैंने बोला
तो चेयर पर बैठ लो। हाँ,
मैं कर तो क्या वो टिक करना है ना पेपर पे वो पेपर एक आईसीयू से मंगाना है यार मैं लेके आ
in the theatre.
वही है अपना पुराना वाला जो दिखा
I think you can go into the settings and mute all. Maybe.
yes, sir, just
yeah.
doing it.
वहाँ मेरी पर्पल पेन गायब हो गई क्या
हाँ, अपने को कितने देता हूँ?
मैं लेके आती हूँ सदनाथ से
In the open surgery, the main changes that have happened is ligation of the inferior thyroid artery as close to the thyroid as against what we used to students. We used to ligate the inferior thyroid artery at a distance. The preservation of the parathyroid has become supremely important now. Today, people are less worried about the recurrent laryngeal now that you have to be adept at that. You have to be very, very adept at preserving the parathyroid blood supply. That to me is the main change that has occurred in the open surgery. Whether you divide the strap muscle or you don't divide the strap muscle, there are very many case to case differences and sometimes even personal differences. I can't think of any other change that has happened in the last 50 years or even 200 years. Ashok, you will be able to
Yeah,
see.
the Karthik asked a very good question. Are we compromising the safety against the scar? And I'm not convinced that we are compromising. I think those who are very good endoscopic surgeons, they do a remarkable job. Now, if we analyze it very critically, in the low risk thyroid cancer, 1 centimeter, 2 centimeter, I think the remote access is very appropriate because you are beyond the whole thyroid, beyond the tumor. But let's say you have got 4 centimeter thyroid cancer stuck to the trachea. I don't think the remote access is very good with that. But that's my personal belief. Because you want to get a better exposure of the entire thyroid. You want to do an oncologically best operation today so that the risk of recurrence is minimal or negligible. So I think one needs to decide himself whether this is the right candidate or not. Now, if you have micropapillary carcinoma below 1 centimeter, whether you do active surveillance, you do the ablative procedure with RFA or minimally invasive remote access surgery, I think the results are same. So my feeling is the surgeon needs to decide what is the best approach in consultation and or discussion with the patient and the family. They should not feel that I'm going for surgery so that I don't have a cut in the neck. There was initially when it started in Korea, there was a lot of discussion that the Korean culture or the Korean women don't want a cut in the neck. Now that is appropriate if you put it in right perspective. 20 years back when there was no remote access surgery, everybody went for open surgery. They were living happily. The culture didn't come in the picture till we invited the culture and said, hey, the young women don't need a scar. And I think we need to put it in perspective. I think this is a technology which majority of the thyroid surgeons should be familiar with. Even though I don't do it, I know exactly who deserves it, who does not deserve it. And I would rather send to somebody who has expertise and take care of it much better than what I can do.
So we will be discussing now in this panel about the various management options, ideal patient selection for these techniques, what are the different remote access approaches, the techniques used endoscopic versus robotic, the complications which we can encounter in these approaches, the cost and learning curves involved, and the final take-home messages. So we'll start with the treatment options. So let us dive into our first clinical scenario. So it's a 35-year-old female who is having a 8 millimeters proven papillary thyroid microcarcinoma, and it's away from the trachea or recurrent laryngeal nerve or any other critical structure. So, what are we have management options, which is surgery, which is a hemithyroidectomy or lobectomy, or active surveillance. So, again, so I'd like to start with Dr. Shah. So, now we know that guidelines do support active surveillance for this 8 millimeter nodules, but the patient is anxious and she wants it out, but she refuses a scar. So, by offering robotic surgery, do you think so we are over treating just because we have a fancy tool? What is your say?
Well, there are two issues here. Is active surveillance appropriate? Absolutely, yes. You can see in 6 months what happens. The 8 millimeter nodule becomes 12. Yes, she needs surgery. Now, so active surveillance is a way to go in microcarcinomas. I have no doubt about that. The only thing you can argue is she's 35-year-old. She's going to live another 75 years. Do you want to invest time and energy? All of us will be retired or dead. So we need to make a decision what she wants to do. If she is overtly anxious, surgery is the best choice. Now you divide the surgery into remote access or open surgery. Again, we would offer open surgery, take a look at the paratracheal lymph nodes, etc. But if she is very anxious, doesn't want a scar in the neck for whatever reason, I have no hesitation in sending her to Siddharth or to Rakesh and do a remote access surgery. Absolutely no doubt about that. Can we do the ablation? Yes. The problem with ablation for carcinoma is our experience is limited. And we don't know what happens to these tumors in 5 years, 10 years, or 20 years. We do know about the active surveillance because we have been doing it at Memorial for more than about almost 15 years. Akira Miyauchi in Japan has been doing it for 30 years, and the results are excellent.
Right. So, my next question was to Dr. Deepa, madam. So, madam, we know that radio frequency ablation is definitely for benign nodules, but can we use it for these small malignant cases also? What does the literature say, madam?
So again, like Dr. Shah mentioned, the literature is just evolving in this area. Most of the data is for benign nodules, and I agree with Dr. Shah. there's a lot of enthusiasm to go ahead for RFAs, but I think we have to always take it with a bit of caution. And the literature again is not very clear because most of the data which is there is on benign nodules. So RFA again is something which is, at least in my book, I would be a bit hesitant to offer it in the primary setting, especially for young patients with malignancy.
Okay, so
Well said,
let's.
Dr. Nair. Completely agree with you. I just want to tell there are three ways of ablation. One is the RFA, radio frequency ablation. The other is laser, which is very popular in Italy. And the third is microwave ablation, which is getting popularity in United States, but very popular in China.
Okay, so just to reiterate, so active surveillance is, as Sir said, definitely an option for these less than a centimeter malignancies, but they should not be away from the critical structures, and even if they grow, they should not invade these structures. And even the ATA gives a recommendation that active surveillance may be offered. And regarding radio frequency ablation, I got this review which says that it can be considered as a first line treatment option for benign nodules, and in malignant cases it can have a role in patients who decline or are not surgical candidates. So in those patients we can think of using radiofrequency ablation. So now we move on to the ideal patient selection. uh, so uh,
Karthik,
this,
can I just make a comment here? One small observation, Dr. Sandeep here.
yes sir, please go ahead.
See, whenever we have, one problem which I see with ablation, even when it is done for benignness, in the follow-up, very often the sonologist confuses the scar for a new growth or anything like that. So very often I've had patients being reported as Tirats 4 5. So there it confuses the picture very often in the follow up. So I don't have much experience with malignant nodules being ablated. So I don't know if there is any other comments on this. It was rather it's a question rather than a you know. So if anybody else has seen this problem or observed this, I would like to take an input from others.
The follow-up after any ablative therapy with the ultrasonography is a technique by itself. You need a sonographer with expertise and a
Yeah.
surgeon who is following the patient with understanding what was done and what needs to be followed. And that's part of the problem of ablative treatment. We don't know exactly what happens to that nodule. Does it disappear? Does it become a ghost? Or does it in future follow-up ultrasound looks much more angry and you are more scared about it? I don't know that.
Yeah, that's a challenge, sir. Yes.
Okay, so we move on to now ideal patient selection. So this is table is taken from the a recent ATA consensus on remote access surgery. So as you can see, the maximum size should be less than 6 centimeters in maximal dimension for benign nodules. They say that less than 4 centimeters for the indeterminate nodules, the Bethesda 3 and 4, less than 2 centimeters for the proven malignant nodules, better the 5 and 6. And even for a parathyroid adenoma, also you can do remote access approach. So, here, Dr. Rakesh Katna, sir, I just, in your experience, if we can do remote access surgery for a 3 centimeters papillary thyroid carcinoma, are we really is the oncological safety compromised? What is your view? Because as we said, a total thyroidectomy can be easily done using these approaches. So can't we remove a 3 centimeters papillary carcinoma with these techniques?
Yeah. So Karthik, I'll just say that here again the basic principle doesn't change. What you'll do for a open surgery for a 3 centimeter nodule, you are going to do the same thing. You can do it in a remote access approach also. So if I'm considering this favorable age group patient with 2.9 3 centimeter nodule for a hemithyroidectomy or just plain thyroidectomy with central compartment sampling or inspection only, I can do the same thing by doing a remote access also. But yes, So far, I'll not go in for a 4 centimeter or bigger nodule, which carries more risk of having a lymph node metastasis or lateral neck dissection is required. So up to 2.5 centimeter to 3 centimeter, you can safely do. But again, the principle is same thing. If you are offering less in an open surgery, as we know, the less is more now. So same thing can be done a remote access approach.
Right. Right. So,
Kar- Karthik, if I may, Deepa here.
yes, madam, please.
Yeah. So again, I think we should understand why this recommendations or the guidelines always tell you that you should be careful in selecting in smaller malignant tumors for remote access. We know that as the size of the tumor increases, the chance of lymph node metastasis will increase. Most of the surgeons who do, like Rakesh just now mentioned, that your plan of treatment should be very clear right at the start. Uh, if you see that if you're going to have a 4 centimeter tumor or more than 4 centimeter tumor, then obviously you're going to have high incidence of lymphatic metastasis. So you should be also adept at clearing the lymph nodes adequately with these remote access techniques, which again sometimes may be challenging depending on which approach you have used in these cases. The other thing is, I think 3 centimeters is something like a cutoff which more and more experienced surgeons are pushing for when they are going for malignant cases in remote access surgery. There's one recent paper from Italy where they compared two groups where they looked at less than 3 centimeters and more than 3 centimeters. And they found that the structural recurrence was not significantly worse if you had even more than 3 centimeters. But of course, the number of patients whom they've operated was less than 50 who were more than 3 centimeters in that study. So it's something which you have to be very careful about. And again, if you're starting off in your practice, you should avoid doing anything which is larger than 2 centimeters, malignant tumors, because you don't want to compromise oncological safety. I think a lot of experienced surgeons may push the envelope a bit more, but again, you have to be ready to deal with surprises of nodes during surgery or extra thyroid extension during surgery.
Extremely good point, ma'am. Uh, we move on to the next on to the approaches. We can see that thyroidectomy scars, they can be as give a permanent reminder to the patients about their illness, and we might close the scar as meticulously as possible, but we do every patient has a different type of healing, and hence these scars may look very bad over a period of time. And hence, these remote access thyroid surgeries have been developed, and they have been found to be a very safe and effective alternative with superior cosmetic outcomes. However, globally, the adoption has remained very inconsistent, and there has been a variability in clinical indications, geographic and economic factors, learning curves, and training infrastructure. And hence, this we are discussing this in the panel. So the general approaches which have been used are the transoral approach, then the gasless transaxillary, the bilateral axillobreast approach, which is the BABA approach, the retroauricular approach, and the rabbit approach, which is robotic assisted breast axilloinsufflation thyroidectomy. So let's go to now the second case scenario. So a 24-year-old female, she is having a 1.5 centimeters solitary nodule in the left lobe of the thyroid with the right lobe normal and no neck nodes. It's a proven for Bethesda 4 follicular neoplasm, and she does not want a neck scar. So let's now, Dr. Siddharth, which is what approach would you like to consider in this case? And also, can you give your experience regarding that approach?
Uh, Hi Karthik. So it's around a 1.5 centimeter thyroid nodule, which is Bethesda 4. So the indication for surgery is because it's a follicular neoplasm. We would like to confirm it's histologically. So that's the indication that for a 1.5 centimeter we are looking at for doing a thyroid surgery. Now, this is a solitary thyroid nodule, and there are various approaches that can be used. Anyone who is familiar to whatever particular remote access. So, I do lot of transoral endoscopic approach. So, I will be sticking to my technique of doing a transoral approach for this patient. But it can be done equally well by Rakesh by transaxillary or by Sandeep with rabbit approach. So I mean this patient is accessible by all means, because probably we are not looking at any nodal dissection particularly in the lateral neck. That is why probably we can do choice between the depending upon our expertise of transoral versus transaxillary or rabbit.
Okay, so can you just tell all of us that what extra things need to be explained to the patient for TOETWA while taking consent?
So while we are preparing patient for
What
this
all do you
TOETWA,
explain?
yeah. So while we are doing this, taking this patient for TOETWA, the major concern that everybody has is like we are going through oral orifice, which is a contaminated cavity, and that is we are going to communicate that with a sterile neck. So apprehension is that we might be contaminating the neck when we approach through this approach. So that is one concern. The another concern are the nerves that are in the vicinity of this area, which is the mental nerve and at times marginal nerve. These are additional to the recurrent laryngeal nerve that we have at the time of the surgery. And third is probably the vital structures in the region, like the trachea and the great vessels. So regarding the oral part, we just evaluate the oral hygiene of the patient, and if that is okay, probably there is no risk of added oral contamination to the neck, because that is quite separate from when we go through the oral cavity. It's a port which is placed, which is connecting the into the neck. So the oral cavity is not directly communicating with the area. Secondly, the nerves, preserving the mental nerves. There is a safety triangle which we follow for the incisions in the vestibular region, and with that, sticking to that region, probably we can prevent any injury to the mental nerves. And taking care of the important vital structures like trachea and all, you have to be as Rakesh was discussing in the talk, like you keep the harmonic non-active blade towards the vital organs, so that you don't damage these structures. So this is how probably we would be communicating with them.
Thank you. So we have got this rabbit approach, which stands for robotic assisted breast axilloinsufficient thyroidectomy. So this is a paper published by Dr. Sandeep himself. It says that we get a very good symmetrical view of both thyroid lobes, and also it helps in maintaining the specimen integrity. So, Dr. Sandeep, I would just like you to help us with your experience, as you have been doing this for many years. And do you think, sir, really we should call this as minimally invasive surgery, or is it's just a remote access surgery, sir? What is your point of view?
This is minimal access. The access incision is small. That's all I could say. But yeah, overall, all these things, would account to remote access thyroidectomy only. Uh, but very often, see, people who regularly do thyroidectomy robotically or with use robotically would tell you that they, enjoy the vision that they get, and that vision, quality of vision makes it a better surgery. So that is my experience also. Over the years, what has happened is, see, initially I also started thinking that, I should avoid a scar in front of the neck. But over the years, what has happened is, I see that the quality of surgery or quality of vision makes me feel much more comfortable with the surgery than I would be with open surgery. So that is how I would put it. So it's more of a, the comfort of the surgeon rather than anything else.
Okay, sir. And can you
Mm.
just tell us the difference between Baba and rabbit approaches, sir?
See, it is a rabbit is a modification of the endoscopic Baba approach. It is one of the ways in which it is done. In if you say typical robotic Baba, they put only 4 ports and they just do the way it was it doesn't use the typical endoscopic Baba approach. Right, in robotically when we do, we use and most of the times they do tooth hemithyroidectomies. The There are those minor variations, like primary port. Many of them use, when it was originally described, it was through the breast. The areola was the first primary port, and through which they started off for robotic. So first published paper I'm talking about, because I started doing this in 2017. Sorry. So the early papers were just coming into picture. So many of the techniques were like that. So there is a list of things which we had described at that time when we were publishing this. So there are a few technical differences.
Right.
There is no assistant port in classical robot, Baba. So those are the few differences.
Okay. Thank you. We move on to the next case. It's a 35-year-old male who noticed the right side level 3 neck swelling since 3 months, whose FNAC turned out to be metastasis of papillary thyroid carcinoma. And USG showed a 1.5 centimeter nodule in the right lobe of thyroid with these right level 3 neck nodes. And left lobe was normal, and there were no other neck nodes seen. So I go to Dr. Deepa, madam. In any which remote access approach would be feasible here, and you would be comfortable to go ahead, ma'am?
So this is a level 3 node positive.
Yes, ma'am. With a nodule in the same side or lobe of the thyroid.
So I, as of now, do not offer remote access when the node is positive, because I would have to do a comprehensive clearance of the neck on the side. But the other, I think Dr. Sandeep Nayak does neck dissection also with it. The feasibility with remote access for lateral clearance is best when you're doing axillary approaches, or when you're doing a bilateral retroauricular approach. A bilateral retroauricular approach is not something which I would advocate. It's just unnecessarily doing too much of surgery. A retroauricular approach I would advocate only if you're doing a unilateral. But if the patient has a node positive, then you know that you have to do this, comes to an intermediate risk, and you would have to do a total thyroidectomy. So if you're planning to do a remote access approach, it's maybe a axillary approach. But my personal philosophy is, if the patient has a lateral node positive, then I would offer an open surgery to this patient as of now.
Okay, so Dr. Sandeep, as Madam said that she would not be comfortable in
Yeah.
doing a remote access approach. So, what is your take, sir? Like your experience in lateral neck dissection using robotics remote access, sir?
See, as a beginner, I wouldn't have given the option at all. See, now we are down about, I think about 350 neck surgeries plus robotically. Currently we are offering to most of our patients, most of our neck surgeries today, unless there is a reason to open, we offer minimal access. Now, when did we start doing it? See, we have analyzed our learning curve because we are also looking at how we have evolved over the years. So we in our learning curve for rabbit, where I'm talking about, we started taking complex cases after 60 rabbit is when we started taking our more and more complex work. Our learning curve, actually beginning, or the early learning curve was 7 cases. Following that, the 30th case is when we started seeing the stability, and after that we were quite stable. Our complications or our immediate postoperative outcomes were quite stable after that. Most of the beginning cases were benign. Then we went on to take up malignancies, and around 60th case is when we started taking more complex work and started doing neck dissections along with it, started taking central compartment dissections, larger glands. So that is when the approach or the maturity of the team started appearing. So, so as of today, we offer uh, most of our patients. We whenever we have to do bilateral neck or even for that matter intrathoracic extensions, most of it is done robotically. We do mediastinal this one. So it is that is not a restriction as of today. But to begin with, it is a restriction. You should stick to smaller glands or smaller tumors and node negative and the entire list of contraindications should be strictly followed. So here, if you ask me, it is a rabbit approach. The advantage is it gives me access to all the quadrants of the neck, all the areas of the neck easily. I can approach even the, in fact, even up to base of skull, you can go with this approach if you want to. So you can do level, all the level lymph nodes on bilateral, including central compartment. You can address the complete central compartment without uh, any difficulty. Vision is very good. So if you have to hop the camera to the opposite side, that is also possible. It gives you a symmetrical view. So that is the advantage which you have with rabbit. Trans-axillary approach, again, you have a problem that you don't get a full adequate access to the opposite side neck. So if you have to do opposite side neck, there are issues there. Pure transaxillary I'm talking about. So you will have to again go with bilateral approaches if you want to do a comprehensive neck dissection.
Right. So the consensus, we all agree that neck dissection is definitely feasible, but we have to go with these axillary approaches, and the absolute contraindications for if the patient is having neck nodes are we can transoral surgery is not possible, and unilateral retroauricular is also not possible.
Yeah, just a point to add, Karthik. So if you see all the meta-analysis network and other things which we discussed also, all those patients, 98% patients were 98 were T1, T2, N0. So again, as said, is Sandeep is saying that's one center of excellence where they have been doing. But otherwise, general message which should go through is when you are neck node positive, generally, it's better to avoid the remote access or until unless you have a very specific center who is doing everything, complex cases. And yes, as we correctly pointed out, unilateral axillary, it's not possible. You have to convert into a BABA approach. Then you make it bilateral axillary best if you want to access that compartment.
So
Doctor, yeah, he put it correctly, Dr. Rakesh.
Yeah.
Yes, sir. So to summarize, Toetva is where you get access and working space through your natural orifice of mouth. Hence, it can be considered as scarless. Its strengths are that it's a symmetrical top-down view of the central neck. So it's very good for total thyroidectomies and central compartment clearances. However, there is a technical risk of injury to the mental nerve, and there have been paresthesia rates reported up to 57%, which obviously will go down as and when you become more confident, and there is a risk of surgical space infection because of oral flora. Then the Baba approach, which uses four small incisions, two in the axilla and two in the areola. And like Toetva, it offers a symmetrical view of both thyroid lobes. It's highly rated for cosmetic satisfaction. However, there is a technical risk involved. It requires extensive dissection to create the working space across the chest wall. And a common complication is chest wall hypoesthesias or paresthesias, which occur in approximately 41% of cases. And the rabbit approach, which Sir just described, so I won't read much about it. And the retroauricular approach, which uses mechanical retractors rather than CO2 gas to create a working space, eliminating the risk of gas embolism. It is excellent for lateral neck dissection, but you cannot get access to a contralateral lobe unless you take the contralateral incision, and it carries a specific risk of injury to the marginal mandibular and beta auricular nerves. So this is a summary. So if you can see that if you compare all the methods, the least invasive, you can call it as the transoral. the complete you get retroauricular approach does not give the access to the contralateral lobe. Central neck dissection is feasible with all methods, but lateral neck dissection is not feasible with a transoral approach. And the best cosmetic outcome, least cosmetic outcome you can say is with retroauricular. So now let us move on to the techniques used. So comparing endoscopic and robotic. So robotic offers a very good three-dimensional magnified view. It removes this hand tremor filtering and gives wristed instrument movements. However, it's more expensive as compared to endoscopic instruments, and endoscopic instruments gives a good haptic feedback. So we are able to feel the tissues. So, Dr. Katna, you have experience of using both instruments. So, can you tell us which one do you prefer more and why?
So, to answer that, I have more experience with the endoscopic as compared to the robotic. But yes, robotic gives you a very good magnification. So, the dissection plane is very good. So, I'll still say that I'm in learning curve of my robotic thyroidectomies as compared to the endoscopic. So, right now, if you give me a choice, I'll still prefer endoscopic, but maybe robotic is definitely advantageous in terms of the wrist movements which you get with your instruments, plus your magnified view is absolutely very good. Yeah. The only problem, one more, is in Indian setup is the cost. So that is also adds on to a cost issue.
Right.
So Karthik, what I say is in robotic, the camera is still in the surgeon's control.
Yeah.
So you can take the camera wherever you want and you can view. I mean, in endoscopic, the limitation here is you have to train an assistant to make you see what you want to do. So that's a teamwork that needs to build up over a period of time, and that's the major limitation between that is one of the other limitation between the two.
Yeah. Right.
So we move on to the complications. So we will again start with a case scenario with the most dreaded complication. So it's a 32-year-old healthy female undergoing TOETWA for a 3.5 centimeters benign nodule. So 45 minutes into the procedure, while creating the subplatysmal working space, we just hit a small perforating vein near the clavicle, which bleeds briefly and then stops, and suddenly your anesthetist says that the end tidal CO2 has just dropped from 35 to 15, and the BP has also dramatically fallen down. So, Dr. Siddharth, what is the immediate step which we need to do in such a scenario?
So first thing is to stop CO2 insufflation immediately. Make the patient in reverse Trendelenburg position so that even if because this is a CO2 embolism that we are looking at, and stop the procedure. If at all there is a way that you can seal that vessel, then probably yes, you can seal that so that there is no active bleeding or any further CO2 embolism happening, and maybe it's the time that you should convert it to open rather than venturing further into the remote access approach.
Right. So to summarize, yes, this is the dreaded CO2 embolism. So as Sir said, in such a case, the protocol to be followed is that you immediately stop the CO2 insufflation first. Then you have to deflate the neck. So you can make a small incision outside and flood the field so that it prevents further air entry into the vein. Then there is something called as a Durant maneuver, where you put the patient in lateral decubitus position, and you also do a Trendelenburg position, and finally you give CPR and provide 100% oxygen. So I want a consensus of all the panelists. If any, I don't know whether you have encountered in your experience or no, but in such a scenario, do you want to abort the surgery and let the patient wake up, or you want to convert to open and finish the job? What is the consensus of all the panelists?
So I think if I mean it depends upon the amount of CO2 embolism and how the anesthetist give us the feedback about the patient condition, and if the patient gets stabilized with this all maneuvers and probably he's safe or patient is safe to undergo further surgery, you make finish off the procedure, or otherwise you may just stop the event procedure, and maybe you can take it for the later date.
Oh, okay, Dr. Nair or Dr. Sandeep.
Shall I?
Yeah, please, sir.
Okay, so see, um, I have to date not faced a single case of CO2 embolization. So, but what I have seen, whenever what happens is, this is a particular problem which we, think about in surface accessible organ surgeries. So typical scenario wherein, neck surgeries or some other organ, like for example, we do breast, we do inguinal block dissection, veil. So these are the scenarios where we can face it, uh, and a rise in EtCO2 level, which happens because of excessive carbon dioxide, absorption. So, typically you will see a raise in EtCO2 and BP shoots up whenever that happens. Patient's BP shoots up. So typical embolization is extremely rare, and the EtCO2 generally raises also when you end up opening a vein in the neck or anywhere else. Now, when you see it is opened, so the first step should be, if you are able to identify it, you can clip it, but put a neuropathy or a small, gauze piece. You can, what we call a spat. We usually prefer to use a neuropathy rather than anything else. So pack that area. You are seeing bleeding, you can easily pack it, because the torrential bleeding of open surgery does not usually happen in the neck. Generally, it's extremely rare to happen because with the CO2 pressure being there, anything above the pressure of central venous system pressure, which is about 6, right? The bleeding of that nature is very, very rare to happen. So you can easily control it with a simple one small patty or something like that, and that will avoid CO2 being sucked into the central venous system. So once you do that, you can always control it and proceed with surgery. Gross CO2 embolism is extremely rare to encounter. At least I have not seen it happening in my superficial surgery experiences across the systems, surface accessible organ surgeries. I have done more than about 600, 700, or more than that, probably I have not counted, including endoscopic surgeries I'm talking about. So I have not faced it till date, but it can happen tomorrow. You have to be ready for it. Now, will I abandon unless the patient is absolutely unstable, like cannot proceed? I would abandon the surgery, but you need to stop the bleeding, right? Under CO2 pressure, bleeding will not happen so easily. So, in fact, most of the bleedings which I have faced, if my assistants are not being careful and we have to take up the patient later, it's basically because we had not deflated the cavity before closure. You have to reduce the pressure and check before you close. So these are the important points which are to be kept in mind whenever you use CO2. Uh, Embolization, if there is a contamination of CO2 with nitrogen, there is a risk. And if the for some reason you ended up pushing some air into the system, that is where the risk increases significantly. And what you have shown over there, that CO2 embolization protocol, management protocol, is similar to nitrogen or air embolization protocol. It's same as air embolization protocol, in fact. So same steps have to be taken. But otherwise, CO2 by nature, by physiology, the carbon dioxide simply dissolves in the plasma, right? That is how physiology is. CO2 simply dissolves in the plasma. The moment it comes in contact with blood, it gets dissolved in the plasma. That is how it works. So the embolization risk is very low. It gets absorbed and it gets eliminated from the system very rapidly.
Right, sir. Excellent point, sir. So, to just for learning sake, sir, any absolute upper limit, what is the limit you keep, sir, for CO2 pressure? And in your experience, does low pressure compromise your view?
See, in surface accessible organ surgeries, you just need to lift the skin flap. It's not the wall. So we can manage it even at around 5 to 6 millimeters of mercury. But upper limit is 10. We do not cross 10. Flow is not a problem. You can keep the flow high, but keep the pressure low. Okay, so generally today, nowadays, we operate at around 6. 6 is our usual standard for surface accessible organs.
Okay.
Yeah.
So there are few complications unique to the different approaches. So important ones are mental nerve injury for the transoral approach, or the brachial plexus injury can happen with the axillary approaches, and in general the CO2 embolism as we discussed. So Dr. Siddharth, how do you explain to a patient that like is a permanently numb chin really a better outcome than a 3 centimeter scar? So how do you explain this risk to a 20-year-old patient?
That's a good question and good point. Yes, we do not want to add on to the morbidity of any procedure by doing it remote access. So if we do explain every patient that there is a possibility of temporary numbness, and that numbness generally resolves within 4 to 6 weeks. That is clearly explained to every patient, but there is always a risk of long-term injury if we are not very careful during the procedure. And so yeah, you have to weigh between the benefit versus risk. And if the patient is not at all willing for this procedure about having this numbness in the chin, you may not be pushing it for the transferal, and you may give a open surgery.
Okay, so Dr. Katna, do you think that long hours of docking for these robotic transaxillary approaches, is there a chance, like, have you had any experience of brachial plexus neuropraxia or anything? And is there any way we can prevent by using now monitoring or anything?
So no, Karthik, earlier we used to, when I started with endoscopic, first few 3 or 4 cases, we used to keep the axillary, the arm abducted. Now we have stopped doing that. We keep the arm like in normal position, what a normal conventional surgery would you do. Even for Baba approach also, when you are doing the docking, and arms need not to be abducted at all, because you can use the same axillary, anterior axillary fold with that. So with that, the risk of brachial plexus, if you see the data also, initially there was reports of brachial plexus injuries, because everybody initial reports in 2001 to 2010, because they were using hyperabduction at that time. So that is not the norm now. So you can prevent the brachial plexus. Otherwise, you need not to use any separate nerve monitoring for that matter, and you keep the patient in the normal position only. Yeah.
And
Additionally, you should always be careful about your pressure points. Always put your pads, Gamgee pads. That's good practice for any surgical thing.
Any long surgery.
Yeah,
Yeah.
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 Any long
Yeah.
surgery, please take care of the pressure points.
excellent point, madam. These are the standard rates which have been described in literature about the various injuries and nerve palsies. So, the highest is with the mental nerve only in transoral, with some literature quoting as high as 57%. Uh, so then we move on to summarize. Remote access approach are not minimally invasive surgeries given the extent of dissection required to establish the working space. They are technically challenging, and IONM may help avoid palsies, and unique risks should be discussed with patients as a part of the informed consent process. Now we move on to the cost and learning curve. So we have to address this price of beauty. So robotic surgeries can cost 3 to 5 times more than our traditional open surgery, and even the learning curve is very significant. Like open surgery may require only 20 cases to become very efficient, while your transoral may require up to 50 to minimize complications. So as we can see in this graph also, it's like there is a cost, very massive cost disparity. So I would like to first start with Dr. Sandeep. In a no, like if a patient does not have insurance or we are in a resource limited setting, how can we justify the cost of a robot or a endoscopic setup for just a benign goiter, sir? So your comments.
See, uh, if you're talking about benign cases, the indications for surgery are extremely limited. Right. So, before we offer surgery itself, we have to think whether the offer to give surgery or offer surgery itself is correct or it's not indicated. Uh, After that, it is the comfort of the surgeon and the patient's requirement or patient's perceived requirement is what you have to really address in this case. So, if a patient feels no, I would be served better with a scarless surgery, then you are justified in offering what you have. Now, endoscopic or robotic is again surgeon's option because comfort of the surgeon in offering what they are offering is what is most important. Now, when that happens, it depending on your facility, what you have in your setup, you have to offer the patients. And see, there are times when I have offered the patient, or they come to me for robotic surgery, but they realize they cannot afford it, and they have some patients have definitely opted for open surgery with me. They have opted for open surgery. So it is something which we have to look at case to case basis. So when it comes to health, you can't weigh health and the outcomes with the amount that you spend, right? So that is how that's what I would say. Yes, the hospital side of it, I think nowadays, a robo is coming into every hospital. There is robotic surgery will be, or some form of some form of robo or robotic equipment will be, invading into every operation theater in the coming few years, because it is a similar scenario to the laparoscopic system. Once upon a time, laparoscopic system was not available everywhere. I'm not talking about few, not. It's just a decade ago. Many of the setups were in Bangalore were looking at not having a 4K system, and today it's available everywhere. So that is how technology works. Technology does, once we prove a utility for a technology, it starts moving into everywhere.
Right, sir. So
Uh,
I would like Dr. Pradhan sir and Dr. Shah Ashok sir's views on this, sir.
Let me make two comments. I think one of the things that you brought up the issue about the cost. I think the whole idea of remote access thyroid surgery is trying to avoid an incision in the neck. That's the bottom line. At what cost? What experience? What is the learning curve? What is the technology available in your institution? Is your business to decide. And somebody like Siddharth or Rakesh, you are expert. Dr. Nayak has given a nice discussion about it. And I have absolutely no reservation in sending the patient to them if the patient want to incur that cost. In the United States, you have to realize the majority of the patients, their payments are through the insurance. And insurance pays the same amount, whether it is open surgery or endoscopic surgery. And that's part of the reason why we don't want to spend 4 hours in our earlier experience rather than doing 4 cases a day. Will this change? Probably, yes, it will change with the younger generation who is technically very good and they understand the robotics very well. I'm sure there is a future. That is one point I want to bring up. The second point I want to bring up, which has not been discussed and reported in the literature, is no matter who does the thyroid surgery for cancer, I'm talking about not benign nodules, there is a 5 to 10% recurrence, either in the thyroid bed or in the lymph nodes in the neck. We have no experience or data in the literature. When you do the endoscopic surgery, what happens to these patients in future? If they need second surgery, how do we go about it? We spend enormous amount of time initially to convince the patient that I'm going to avoid the incision in the neck because you will still continue to look beautiful. And now we have no choice when there is a lymph node at level 2 or level 3 to do an open neck operation. I don't have any data on that. This is something that is lacking in the literature. And the last thing I want to bring up, which I don't think we got much chance to discuss, I think Dr. Deepa Nair alluded to it. There was a lot of interest once upon a time when there is a lymph node positivity to do a total thyroidectomy, neck dissection, and RAI. That was the standard of care, I would say, up until last 5 to 10 years. Things have evolved quite a bit in the United States. There is a major shift in avoiding total thyroidectomy and radioactive iodine. So today I would feel very comfortable in that patient, Karthik, that you showed, 1.5 centimeter unilateral thyroid nodule with level 3 node. I would do a neck dissection, ipsilateral lobectomy, no RAI, and just monitor the patient. I tell you why I'm bringing this up, because that will maintain the best quality of life. If you take 100 patients with lobectomy and 100 with total thyroidectomy, the patients who have undergone total thyroidectomy do much worse as far as the quality of life is concerned. They just don't feel well. Just think about it. You are 35 and you're going to take thyroid medication for next 75 years of your life. That's hard. That's not easy. And especially in a young woman who wants to become pregnant, breastfeed the baby, I think lobectomy is much better operation in my judgment, maintains the best quality. Some of them may require thyroid supplements, but it is not replacement. And the last thing I want to bring up, there is clearly a defined complication rate between lobectomy and total thyroidectomy. The worst complication in total thyroidectomy is bilateral nerve injury or permanent hypoparathyroidism. When that happens, you feel you want to leave the surgery and go to become a yogi or something else, go in Himalayas and live there rather than doing surgery in Mumbai. So those are my major comments. I think we need to put it in perspective. I must say the three endoscopic surgeons were very honest, good information, good experience, and congratulations to all of them.
Thank you. Karthik, can I say a point?
Yes, sir. Please go ahead.
So when you ask like how to justify the cost versus so basically it's like Apple want versus need. So if that person needs a scarless procedure, probably there is an added cost to achieve that need of that person. Otherwise, open thyroid surgery is always an option available. So
Right.
it's not pushing towards those access approaches, remote access. It's like the need, you satisfy the need of that person who wants it. So probably that is where the cost can be justified.
Right. Point well taken. So, if you look at the outcomes, if we compare remote access versus open, so the ATA in their consensus statement suggested that oncologically the outcomes are equivalent. So, they are very similar to open surgery regarding the recurrence rates and the nodal yield. The functions are also preserved, and the voice and swallowing outcomes are similar or even sometimes superior as compared to conventional methods, and of course with superior cosmetic outcomes overall. So hence remote access approaches are here to stay. Now, regarding what does the ATA say that with surgeons who are performing at least 25 thyroidectomies annually, they can offer remote access surgery. So now my question to Dr. Deepa madam, in an academic center, it is possible that you get 25 thyroidectomies using remote access approaches, but in a private setting this number may not be possible. So do you really think that uh, so many surgeries are required to stay in touch with your skills, and what is your take on this?
So, from what I understand of this consensus statement, is that if you want to offer remote access surgeries, you should be doing 25 thyroidectomies, not just remote access thyroidectomies. Because what we need to understand is that you have to be very well adept with your anatomy in an open thyroidectomy. The access changes, but the surgery does not change. And if you are not confident in your open thyroidectomy, you have no business doing a remote access thyroidectomy. Now, with regards to the learning curve for remote access surgery, I think there are various papers, and you've also alluded to it. Your uh, when you're doing for retroauricular remote access, the learning curve is slightly lower because the anatomy and the access is pretty much similar to an open surgery. When you do endoscopic, it depends on what your basic training is. If you have trained in laparoscopic surgery like general surgeons have, it becomes slightly easier. But for ENTs who don't do endoscopic or laparoscopic surgery and are not adept with laparoscopic instruments, example for me, I found it much easier to directly jump onto robotic surgery, which is much more simple to adopt from open to robotic compared to open to laparoscopic. But again, when you talk about it for like for a TOT, that is a transoral robotic thyroidectomy, what they say is that your learning curve is a minimum of 20 to 30 cases. Now, you also have to understand that unless you do these cases in succession, if you do one case in 6 months, you're never going to overcome the learning curve. You have to keep doing them more frequently to get over this learning curve. So it is a bit of a challenge, especially if you're going to do it in a low volume setting. And that's where maybe an academic center is better to do this when you're training. And Dr. Shah said that maybe you should consider a short-term fellowship where you can actually get some hands-on experience to do this. Because if you do one case in 6 months, you're really not going to overcome your learning curve, and the complications are going to be much higher in those cases. Your time of the surgery is also going to be higher. So in Tata Hospital now, we've been doing robotic thyroid surgeries for the last 2 years. And initially, what our talking time was around 180 to 200 minutes has come down to less than 90 minutes. So it is, the robotic time. So it obviously is a function of as your experience improves, the amount of time and the complications will be much lesser. But you can't do this unless you are a high volume open thyroid surgeon.
Right. Point well taken. So this is where the next consensus statement released by ATA says that a proper training program, which includes cadaveric dissections, clinical observership, and on-site proctoring for the initial cases, is likely to result in better outcomes, as Madam said. So the key elements for remote access surgeries are you should have good institutional support with qualified surgeons. You should have consideration of cost involved and a thorough preparation, that good patient selection, a good radiologist to denote all the findings. So before we end, I would like one take-home message from each of the panelists for our audience. So let's start with Dr. Pradhan, sir.
All I can say is a repetition of what Ashok has said, that the main advantage is that you don't want a scar. And if in your center the work volumes are very high, one is very reluctant to start this kind of patients are in an extremely price sensitive. The hospital is in a very, very price sensitive market. So your volumes are very high. You're not able to complete your operating list every day here. In this hospital, we have 7 to 11 operations, major resections every day. Accommodate one such thyroid surgery. Surgeons want to have, surgeons want to develop newer things. But the advantage is only this, the scar, only that much. And that is why the motivation to take this on is not very high. And I dread when Karthik will keep pushing me, sir, I want to do it, I want to do it, I want to do it. I tell him, go to Dr. Katna, go to Sandeep Nayak, go and learn there and then come. It's good. Surgeons want to enjoy surgery. Surgeons want to develop surgery. Surgery will never plateau. Surgery will never plateau. It will always keep increasing, get better and better and better. So yes, there is scope. The advantage is only scarless. And no other advantage. And when I saw the way I enjoyed watching you, Siddharth, doing the tour or whatever you call it. But I lost all that enjoyment when I saw the struggle,
Yes, sir.
the struggle for extracting it. It was just mashed up, completely mashed up, and how much struggle was there to extract that from the oral cavity. And I thought, God, this is not for us. In any case, it's for, at least as of now, it's predominantly for benign cases. It's not for me. But yes, Karthik, I will encourage you to go and learn it. I won't stop you. Learn that.
Thank you, sir. Dr. Shah?
Well, the important issues I think we have covered quite a bit, and you have summarized it very well. I just want to go back to the biology of thyroid cancer and adhere to the principles of what we are practicing now, de-escalation. It's not the de-escalation of cancer treatment. It's a de-escalation of the extent of the disease, surgery to adapt to the best operation for that particular cancer and trying to render the best quality of life. I don't think in the olden days we ever thought about quality of life. We have several patients operated by Hayes Martin with a radical neck dissection, and they come for follow up. They are happy 45 years later, but I'm very unhappy that we did a radical neck dissection once upon a time, which was the standard of care, and now we have moved quite a bit. So the entire idea of the ATA guidelines, the 2025 guidelines, is to de-escalate the treatment. And there are two papers recently about the neck dissection and lobectomy only. One published by us in JAMA Otolaryngology last month, and the other one which came last week in Thyroid from Japan with a editorial comment by Michael Ye from UCLA, trying to de-escalate the surgical treatment even with nodal disease. What has been experienced all around the country and in the endocrine world also is the radioactive iodine does not help much in majority of the patients with thyroid cancer. Only a minority, young kids with pulmonary metastasis, it has some help. Otherwise, it does not help. So the bottom line is understand the biology, understand your experience, your institutional practice, and who is the best for remote access. Let him enjoy the expertise rather than me, who I don't know much about. Keep in mind, we are 13 surgeons at Memorial, active surgeons. None of us does the remote access surgery today. And there must be a reason behind it, why we have not proposed so much or pushing the envelope. Again, I congratulate all the three speakers who have done a fantastic job in their own career.
I would have liked to see the video from Dr. Sandeep Nayak. I think that would have been nice. Karthik, you arrange for it next time.
Sorry, sir. Can you repeat again the video from?
Invite Dr. Sandeep Nayak for a demonstration or
Yes, sir.
for his
Sure,
video.
sir.
For his video, we must see that.
Yes, sir. We'll do, sir. So, Dr. Sandeep, can you just give a final take-home message of our audience?
So first of all, thanks for having me, and thanks for the gesture from sir to call me to or invite me to present or give a demonstration. Also, it was a nice gesture. Thank you, sir. See, the uh, see, I always have see at the end of the day, what we are doing is for our patients, and we have to keep our patients at the center of what we do. So the results are extremely important. So technology is only as good as the operator. We cannot be like, if you are not able to, if you have to look at your results yourself and take it forward with the with analyzing your previous cases, how they have performed, what you have done, what complications you have had, and was that complication justifiable? Because at the end of the day, if you have say perforated a trachea trying to do a robotic surgery or injured the recurrent nerve, so these factors you have to look at, and you have to critically analyze your data at every step to see what you are doing. Because at the end of the day, worldwide data is not what you're looking at. You're looking at your personal data. So if you are a better open surgeon, you should continue to do open surgeries, and you have to do, or you have to go deliver a good outcome to your patient. So the my advice to younger surgeons is, you need to learn the technology and technique. Go to a good center where there is good volume and learn how to perform these techniques. Find the technique which is good for or good in your hand. Like, like Buddha said, no, you have to find your own truth. So he said, don't follow me, follow what is true for you. You have to find your technique which you are comfortable with. So, and then use that technique to deliver the good results for your patient. So that would be my message. Thank you.
Thank you, sir. Dr. Deepa, madam.
So thank you. I think it was a very interactive session, and I really enjoyed all the comments. The videos were excellent, and I think that's a very short message from me that yes, remote access surgery is here to stay, and we need to keep our minds open and train for it. But don't be, as Dr. Nayak very well said, do the best surgery for the patient. Uh, Recognize your limitations, train to overcome it, and choose the best surgery for the patient in front of you at that point of time. So don't try to fit your surgery to the patient. I mean, you should choose the appropriate technique, the appropriate approach, and be very honest with what your abilities are, and keep training to improve yourself. So all the best to everyone.
Thank you, madam. Dr. Katna.
Yeah, so I'll just continue from what Professor Shah sir said. So as we are de-escalating the treatment, these modalities are more to appear now. Because if you're embarking on less thyroidectomies, hemithyroidectomies more or something, this definitely has a place to stay. And as everybody said, only important thing is first, all for all juniors, be a good open thyroid surgery. So until unless your anatomy is perfect, whether you're doing a transoral approach, transaxillary, BABA, whatever approach you are doing it, you have to find the structure in the same way only. You have to adapt to the conventional open surgery. You should be very good at that. Then you go and train yourself in this thing. And definitely learning curve is there, but that is there with all the procedures. And most important is your patient selection. Okay, one size does not fit all. Here also the same thing. You have to choose your initial patients very wisely, then only you can push the indications later once you are well versed into that, otherwise not. And I'll still say gold standard as of now, after that still you have to fall back on something, is your open conventional surgery.
And Dr. Siddharth, sir, to end our session.
First of all, thanks Karthik sir and Pradhan sir for this great opportunity. Thank you sir for the warm invitation to demonstrate at HNCII. Yeah, there was a bit of struggle, but yeah, we'll figure out something for that so that it becomes more enjoyable. And lastly, I think everybody has very nicely put up the comments about how do you take this remote access thyroid surgeries. So this is not a minimal invasive surgery; it is a remote access surgery. So there is a dissection which is more than open surgery, but it's only the cosmetic benefit that you get, and that is what is to be practice. I mean, that has to be taught to the patient that this is the only difference. That is the only difference between open and this remote access is cosmesis. So if the person or the patient is truly requiring that benefit, then only this should be kind of pushed rather so take the opinion of the patient, look for the demand or the need of the patient, and then you can offer the options that you can give them. So all the best to each and every speaker who have really put up great points. Thank you Pradhan sir and thank you Ashok Saha sir for the wisdoms that you have given.
Okay, so thank you, sir. So we end over here. Thank you to all the panelists for giving the precious time and enlightening our audience. And thank you for everyone who has joined our meeting today. And thank you again, Pradhan, sir, for giving me this opportunity. Thank you, everyone.
Thank
Great
you.
job,
Thank you.
Karthik. Wonderful.
Thank you. Thank you,
Thank
sir.
you
Thank
sir.
you.
Thank you all.
Thank you, Karthik.
Thank you, sir.